welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today, we have Mallory McGee, who is a PGY2 emergency medicine resident at Froedtert and Medical College of Wisconsin. Today, she will be presenting a journal club on magnesium sulfate versus lidocaine as an adjunct for renal colic in the emergency department, a randomized double-blind controlled trial. Thank you.
Some of our objectives today will first understand renal colic and current recommended treatments for it. We'll review some prior studies and then evaluate the study and discuss the clinical application. The study purpose briefly is, of course, to evaluate the use of IV lidocaine versus IV magnesium as adjuncts to intramuscular diclofenac for analgesia in patients experiencing renal colic who presented to the emergency department. The authors really deem this an important study in order to reduce the use of opioids and if lidocaine or magnesium could help in those adjunctive situations. A little bit of background. First, just to start, of course, what is renal colic? Really, this is severe acute flank pain, typically originating over the costovertebral angle or the CVA. This is generally associated with acute obstruction of the urinary tract, however, could also occur from other disorders such as ureteral spasms following a stent removal or ureteroscopy. And the pain really is a result of proximal ureteral renal pelvic dilation, which really results in this immediate intense pain known as renal colic. And really, again, there is typically no pain associated if there's a stone within the kidney itself. It's when that stone moves into the ureter and causes some sort of obstruction of urinary flow, stimulating submucosal stretch receptors in the ureter, renal pelvis, and capsule, resulting in this pain. And this is important because there's over 1.2 million emergency department visits a year in the US due to renal colic, and about 20% of these require hospital admission. And not only is there these 1.2 million visits, but patients that do have a new stone formation have approximately a 26% likelihood of at least one additional symptomatic renal colic attack within 5 years of their initial event. So pretty commonplace and something that we could see a lot. To get into some current guideline recommendations, first to start, neither the 2007 European Urology Guideline for Management of Ureteral Caliculi or the 2019 American Urologic Association Guidelines for Medical Management of Kidney Stones include any recommendations on the management of addressing this acute pain. What I did find, however, was an update on management of renal colic in the Australian Journal of General Practice, published in 2021, and they recommend first-line NSAIDs, and those had been shown to be superior to opioids in terms of their efficacy. They then recommend opioids as adjunctive treatment as a second-line option if NSAIDs are contraindicated or are not sufficiently treating the pain. These are the only two drug classes mentioned within that 2021 guideline. The second guideline I found was renal and ureteric stones assessment and management in the 2019 National Institute for Healthcare and Excellence Renal and Ureteric Stones. And they, again, first line recommend NSAIDs, and then you could consider IV, essentially acetaminophen was what we would use in the US. And then if neither of those work, then you could consider opioids. And then they did specifically say or recommend against antispasmodics. So after the guidelines, we can talk about a few previous studies that had been conducted. The first one looked at evaluating effectiveness of IV magnesium as a treatment in acute renal colic in the ED, published in 2019. And they compared standard of care, so ketorolac, 30 milligrams IV versus magnesium sulfate. And they did find a a statistically significant difference between study groups regarding pain severity at both 30 and 60 minutes, with the intervention group showing much better pain relief than the control group. A different study published in 2019 in AJEM compared the analgesic effect of magnesium and ketorolac in the treatment of renal colic patients. And they administered 30 milligrams of ketorolac again, and then they used 50 mg per kg of magnesium plus ketorolac. And they found that after 30 minutes, the pain score significantly reduced in both groups, with no statistical significance between the groups, however. So this really indicated that magnesium itself did not influence renal colic pain relief. The next study I wanted to touch on was published in 2020, and they looked at IV magnesium for pain management. And they compared IV magnesium to IV morphine. So really, patients received morphine, and then if their pain persisted after 10 minutes, then they would receive either another dose of morphine or the other group would receive magnesium. And they found no difference between the groups, but concluded magnesium is a safe and effective alternative to morphine. The last study I wanted to touch on was published in 2020, and this looks at more of the lidocaine side of our study. And they looked at the lidocaine 1.5 mg per kg and IV ketorolac 30 milligrams. And the combination of the two medications was better than lidocaine alone, however, not better than ketorolac alone at 30 minutes after administration. And then I also wanted to touch on that the lidocaine 1.5 mg per kg is commonly used as a bolus in pain management protocols, especially in the world of kind of the perioperative setting. Now, our favorite part as pharmacists is really getting into the mechanisms of these medications and why they may be recommended first line. So we're all probably pretty familiar with the mechanism of action of NSAIDs, but I wanted to just touch on it a little bit more specifically in this population. So really the current understanding of the mechanism behind the use of NSAIDs is that there is this release of prostaglandins secondary to a urethral obstruction, which then promotes glomerular afferent arterial dilation and increased vascular permeability. This is then leading to increased urine output from the affected kidney and higher renal pelvic pressure, and again, causing this pain that the patients experience. And then the NSAIDs, when they are used, will exert their effects by primarily reducing the prostaglandin production and then thereby reducing the glomerular filtration rate by as much as 35%, and then really reducing this renal pelvic pressure and those stretch receptors within the ureter that is causing that pain. And then I just wanted to point out too that it is thought to be that COX-1 is thought to be in control of these renal hemodynamics and GFR. We'll touch on a little bit when we get to our study a little bit more about specific NSAIDs and their use. And then, of course, magnesium. So this was a new mechanism to me of how it may work in the use of pain. And so it really can actually work as an NMDA receptor antagonist, so similar to ketamine. And magnesium actually has its own binding site within the receptor, as you can see in the picture there. And so this will inhibit calcium influx into cells and ultimately prevent central sensitization, which can lead to that long-term manifestation of pain even after the stimulus is gone. So could have down the road beneficial effects as well. And then, of course, I wanted to touch on the dose a little bit as well. Magnesium has been studied more extensively in the perioperative setting and used doses somewhere around 30 to 50 mg per kg as a bolus, and then often followed by a continuous infusion. And then specifically also in the setting of renal colic, magnesium could perhaps work for controlling the acute pain, really by relaxing those urethral smooth muscle contractions, and hopefully the stone could pass more easily. Lidocaine we're maybe a little bit more familiar with as far as its proposed mechanism for pain. And it's really thought to work in a few different ways to inhibit these pain responses. But the most understood mechanism is in the dorsal root ganglion neuron ion channels, which are mainly voltage-gated ion channels, including sodium, potassium, and calcium channels. Lidocaine can block the sodium and potassium channels and regulate intracellular and extracellular calcium concentrations. And this is important in really regulating the transmission of pain signals through the dorsal root ganglion in the CNS. Now that we have a little bit of background, we will then move into our study. First, our study design and methods. This was a prospective, double-blind, randomized clinical trial from November 2022 to August 2023 in 3 academic hospital emergency departments in 1 regional medical center in Tunisia, Africa, as you can see on the map, kind of north central Africa. Patients' vital signs were collected and then they were randomized in a 1:1:1 ratio to their respective groups. A little bit about their statistical analysis. They calculated a sample size based on a presumed proportion of success of 50% reduction in numerical rating scale pain score at 30 minutes. This was estimated at 70% based on prior studies and using an alpha value of 0.05. And then the findings were reported using descriptive statistics and assessed for normality with the Kolmogorov-Smirnov test. And analysis was performed using attention to treat, and differences were reported using 95% confidence intervals. A little bit about our inclusion and exclusion criteria. Patients were included if they were 18 to 65 years old, they had a suspected diagnosis of acute renal colic, and this suspicion was based on emergency physician clinical judgment or by identifying the urinary tract stone using ultrasound or some sort of imaging, including CT scan. And then patients were also included if they reported their pain score of greater than or equal to 5 using that numerical rating scale. Briefly, to summarize some exclusion criteria, patients that were suspected to be pregnant or breastfeeding were excluded. Of course, if they had any allergies or contraindications to the medications, any renal or hepatic dysfunction, if they had used NSAIDs or any analgesics within 6 hours before they presented to the emergency department, really if they had any, again, contraindications or reason not to use any of these medications, if they had seizures, altered mental status, on anticoagulant medications, or hemodynamically unstable at the time of presentation. Now, the important part are interventions. So all patients received 75 milligrams of intramuscular diclofenac. And then in blinded fashion, they were then randomized within these 3 groups to receive 1 gram of IV magnesium. And this was diluted in 10 milliliters and given over 2 to 4 minutes. Or they received lidocaine 1.5 mg per kg IV, again diluted into 10 mils and given over 2 to 4 minutes, or placebo, again prepared in a similar fashion. And this is where I just wanted to touch on a little bit of the use of intramuscular diclofenac. That is not available to us in the United States, so we would most likely use ketorolac instead. And generally, ketorolac is thought to be more COX-1 specific. So going back to how that is thought to control kind of the renal hemodynamics portion, while diclofenac maybe has a more even ratio between COX-1 and COX-2 inhibition receptors. So just keeping that in mind. And then lastly, rescue analgesia. If patients were still requiring pain medication, so if they were still scoring greater than 3 on that pain scale at 30 minutes after study drug administration, IV morphine could be used as a rescue analgesic. So a little bit more about that numerical rating scale that I've been talking about. So patients were asked to rate their pain according to this at 5, 10, 20, 30, 60, and 90 minutes after initial drug administration. And so no other medications were given to patients during the study period, and patients were followed up 72 hours after discharge to record pain status and whether the patient returned to the emergency department with renal colic symptoms as well. And that follow-up was blinded to, or that investigator was blinded at that time of follow-up. And then also just to touch on this scale, it is commonly accepted that a decrease in pain score or a significant decrease in pain score would be greater than 1.3. So just keep that in mind when we talk about our results. So the actual outcomes, primary outcome, they were looking at the proportion of patients who achieved 50% reduction in that NRS scale at 30 minutes. Secondary outcomes were any need for rescue analgesia if there was a time required for 50% pain reduction and what that was, the proportion of patients with persistent pain, so still the NRS score greater than 2 at the end of the study, so at 90 minutes. Of course, frequency of adverse events and what those were, and then if there was any return to the ED for renal colic recurrence. The baseline characteristics, there were many more listed in the study, but these were just some of the more pertinent ones that I thought, and I wanted to pull those out. So age was relatively similar, around 42 to 44. And then about half and half of male to female ratio. And looking at past medical history, the occurrence of renal lithiasis, acute renal colic, or urinary infection was also similar across groups. The numerical rating scale for that pain, they all started out pretty high at about 8 to 9-ish out of 10. So they were all experiencing pretty acute and severe pain. And then as well as the ultrasound findings were similar among groups as well. Getting into our results now, looking at both our primary and secondary results, and that primary outcome of the 50% decrease in that numerical rating scale score at 30 minutes. And this was found to be more frequent in the magnesium group compared to lidocaine or control. But despite this, none of those pain scores, there were no differences observed between the three groups. If you are looking between them of that greater than 1.3 that we talked about, if you specifically look at the 30-minute time mark up here, they do not differ greater than 1.3. Thinking about secondary outcomes, there was no differences in return visits to the ED, but there was less need for rescue analgesia in the magnesium group. Adverse effects. So I just wanted to pull out the facial flushing, as this was more common in the magnesium group. And we can talk about that maybe a little bit more in the discussion, but maybe this was due to giving it at a rate of 2 to 4 minutes, but up for debate there. Authors' conclusion, they concluded that combining the 75 milligrams of the intramuscular diclofenac and 1 gram of magnesium resulted in statistically more subjects achieving a 50% or more decrease in pain at 30 minutes. However, this did not apply to lidocaine. Despite this, none of those pain scores observed among the three groups at any time point met the generally accepted, the greater than 1.3 threshold for clinical significance. And secondary outcomes, just to reiterate that it was notable for less rescue analgesia needed in the magnesium group. However, they also experienced more facial flushing. Really, to summarize their points there, they concluded that magnesium appears to represent an effective adjunct to diclofenac, but however, still modest in effect. But they found no evidence of benefit for adjunctive lidocaine in this study. A little bit of discussion, some strengths. It was a randomized blinded study with generalizable diagnostics. So using that ultrasound or CT scan, or really just the clinical suspicion of the emergency physician, I think is generalizable to most institutions. Some of the limitations, as we talked about, we don't have intramuscular diclofenac in the United States. And there were also no reported data if patients received other treatments for urolithiasis, if they got lithotripsy, or if they just achieved pain control in the emergency department and everyone was discharged, really kind of what that looked like. It was potentially a little bit of rapid infusion of medications. Again, a point of discussion and maybe just institution specific of what that looks like. And then, of course, as with every study assessing pain, the pain scale is subjective and may vary from patient to patient as far as rating their pain scales. In conclusion, or my personal conclusion, I would say, magnesium, I think I would recommend it due to really its low risk of administration and not a lot of contraindications to the medication. And maybe if patients were to experience facial flushing, we could slow the rate that it was given at. So just longer than 2 to 4 minutes, maybe like 10 minutes. Lidocaine, however, I don't think I would recommend, as they did not find any benefit. There didn't seem to be a lot of other studies that found benefit within the renal colic population. It, of course, comes with a higher risk of administration, especially if patients have cardiac history. And even in this setting, it would be a one-time dose. There's still potentially a risk of accumulation of its active metabolites. And again, it seems like there's more data for it maybe in the perioperative setting, but not necessarily in this clinical scenario. That was all I had for you guys, my references, and then I'd be happy to take any questions that anyone had.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.